This brief film will show hand surgeons how to inject local anesthesia so that all the patient feels is the first poke with a small 27 gauge needle so that it hardly hurts the patient at all. All further needle pricks and injection of local anesthesia is painless. Until 9 years ago, I used to blast in my local very quickly with a 25 gauge needle, like most of us have done for years. The philosophy was, well, this is going to hurt, but not for long. And the idea was to be quick. As surgeons, we use words like, they tolerate it well, which can mean they let me do it, even though it's been kind of awful. And then this man, Dr. Rob Hayes, moved to Atlantic Canada as the first Mohs surgeon in our area. And week after week after week, he would excise large basal cell skin cancers under local anesthesia without sedation in the clinic on Wednesday. The following day, on Thursday, I would blast in my local with a 25 gauge needle to reconstruct these patients. And I'd be talking to them and saying, "What did you think of Dr. Hayes yesterday?" And they would say, "Oh, Dr. Lalonde, he was so nice. And you know, he didn't hurt me at all when he injected the local anesthesia yesterday." Their implication was, of course, that I hurt them quite a bit while I was doing it. After 3 or 4 weeks of this, I decided I needed to go learn from my younger colleague how to inject local anesthesia so it doesn't hurt, and I spent a day with him. Since then, I've also done research projects and learned more about it, and we're going to show you this now. This patient was injected by a 4th-year medical student. So I'd like to ask you how much the whole thing hurt. Could you tell us, please?
I would say probably a 2 on a scale from 0 to 10.
Yeah, compared to going to the dentist?
It doesn't hurt as much as the dentist.
Oh, well, that's nice. And you had quite a young fellow put the freezing in. What did you think of him?
He did a very good job.
We applied these principles to all our hand operations, and that, plus getting rid of the tourniquet, has made a much happier group of hand surgery patients for all our operations.
How sore was it?
Not at all.
What did you feel?
Felt a little tingle when the first needle went in, and after that it was more or less painless.
I only felt the little needle, and that's it.
The only pain that I really felt was a little prick from the needle.
Other than the first needle, I felt nothing. I felt a little prick from the needle when you first put it in, and other than that, there was no pain at all.
Anyone can inject local anesthesia with minimal pain. In this paper published in 2012, we taught 25 consecutive medical students and residents how to inject carpal tunnel patients with minimal pain. 75% scored a hole-in-one on their first try, where the patient only felt the very first poke with a 27 gauge needle. 25% scored an eagle. So you don't have to be skilled or take a long time to learn how to do this. Anyone can learn how to do this if you follow the simple rules that we're going to give you. The usual cause of patients feeling more pain is injecting too fast, moving the needle ahead of the local, or not injecting enough volume. I've stopped using 25 gauge needles because 27 or 30 gauge needles hurt less going into the skin, and they force me to slow down and be patient. The pH of lidocaine 1% with 1 in 100,000 epinephrine is an average of 4.2, which is 1,000 times more acidic than body pH. If you add 1 cc of 8.4% bicarbonate to 10 cc's of this solution, it hurts a lot less at a pH of 7.4. Hold the syringe with 2 hands so that it doesn't wobble. Have your thumb on the plunger. This avoids needles moving so the patients don't feel pain until the needle site gets numb. Most importantly, never let the needle get ahead of the local anesthesia. Hitting live nerves with a sharp needle tip hurts. Instead, always have at least 1 centimeter of visible or palpable local anesthesia ahead of the needle. Move gradually, not in jerks. Always have your finger palpating so that you can feel and see local ahead of the needle. And always say in your head, blow slow before you go. Blow slow before you go. It only takes a little longer to inject this way, but you'll be amazed at how little pain you produce. Insert the needle at 90 degrees instead of 45 degrees. Nerves are like leaves on trees in the dermis. The more leaves you hit, the more it hurts. If you come in perpendicularly, it hurts less. Inject underneath the dermis, not in the dermis. This also is going to decrease pain. Once again, if you're in the dermis, you're injecting into the leaves that the patient feels. If you're injecting under the dermis, they won't feel it. Blow in enough that you can see it or feel it. Blow in at least 0.5 cc's. Then pause and let the needle penetration site get numb. Ask the patient to tell you when the pain of the needle site is all gone before you do anything more. Then slowly stay in that same place and inject another 1.5 cc's. You should inject 2 cc's before you move the needle at all. Once you have 2 cc's in there, then you can aim the needle down and go parallel to the skin, because you'll have at least a centimeter of local ahead of your needle. You can then run underneath the skin parallel to it and go until you reach the hub of the needle. You then need to take the needle out and re-enter the skin. When you re-enter the skin, always make sure that you re-enter in an area that's clearly white with functioning epinephrine. If there's no epinephrine working there, there's no lidocaine working there. You don't want them to feel the needle reinsertion. When patients are afraid of needles, they get a 20 gauge needle for sedation, and they get another 20 gauge needle for preoperative testing. This can easily be explained to patients so that they think that they're getting less pain with a general anesthetic or sedation. They're actually wrong if you inject it properly. When you put the needle in, if you pinch the skin or just press on it, just proximally to where the needle's going in, it creates sensory noise which decreases the pain of needle penetration. It's like hearing a baby cry in a busy airport instead of in the room next to you in the middle of the night. It's important to learn from every patient. I ask every patient to tell me if they feel any more pain after the pain of the first needle poke is all gone. If they feel pain a second time, I score an eagle. If they feel pain 3 times, I score birdie. If they only feel the very first poke, I score a hole in one. I think that every medical student, every resident should be scored when they inject patients, so that they can learn to get better every time they inject. Bupivacaine is a good drug, but not only is it cardiotoxic, the pain and pressure parts of bupivacaine don't last as long. Bupivacaine pain comes back at 15 hours, but the pressure and touch part lasts 30 hours. That's why it is that patients will call you after a bupivacaine digital nerve block and say to you, "Doctor, my finger hurts, but it's still numb." They're not wrong. Bupivacaine is not a light switch like lidocaine. Also, bupivacaine has a higher cardiac toxicity problem, and if you get a good blast intravenously, it will stop the heart. You can rescue this with intralipid, but it's better to avoid it. And lidocaine with epinephrine gives you all the time you need to do most hand operations. Many of us still use the 2 dorsal injection block technique because the first text of local anesthesia, written in 1905 by Heinrich Braun, said that it hurt less to inject in the web space, as shown in the image, than to inject in the palm. Every text of local anesthesia has repeated this since then. We did a paper in 2011 with level 1 evidence where 76 volunteers had needle pokes in both hands, one finger on the palm, the other finger in the web space, and the pain was the same. it wasn't greater to inject it in the palm. Needles just hurt in the hand. And so the least painful block is the simple block with a single subcutaneous injection in the middle of the proximal phalanx with lidocaine and epinephrine. There's level 2 evidence that this is in fact a preferred way to have a block by volunteers. There's also level 2 evidence that if you do a simple block over 60 seconds, that it hurts less over 10 seconds. It only takes a minute to do a digital block that hurts a lot less. So plain lidocaine as a digital block lasts 5 hours. Lidocaine with epinephrine as a digital block lasts 10 hours. Bupivacaine as a digital block lasts 15 hours for the pain control. And adding epinephrine to bupivacaine doesn't add much time.